Hello, this is Roman Stasinski with OpenAnesthesia.com and Anesthesia and Analgesia. I'm here with Dr. Barry Kussman with his article of the month for July's edition of Anesthesia and Analgesia. And the title of the article is Cerebral Oxygen Saturation in Children with Congenital Heart Disease and Chronic Hypoxemia. So Dr. Kussman, thank you very much for joining us.
It's a pleasure. Thanks for asking.
One of the things we'd like to maybe start off with is, can you explain to our listeners what the difference is between near-infrared spectroscopy and cerebral oximetry?
So near-infrared spectroscopy, or NIRS, the term is frequently used interchangeably with cerebral oximetry, but there are some important differences. NIRS is a non-invasive optical technology. It relies on the relative transparency of biologic tissues to near-infrared light, as well as the absorption spectra of the chromophores involved in tissue oxygenation. The elements of tissue oxygenation which NIRS can measure include hemoglobin oxygen saturation, the concentrations of oxy, deoxy, and total hemoglobin, and with advanced instrumentation, it can measure cerebral oxygen consumption, cerebral blood flow, and the redox state of cytochrome oxidase. Oximetry, by definition, is a measurement of hemoglobin oxygen saturation in blood or tissue. So cerebral oximetry only measures hemoglobin oxygen saturation in brain tissue beneath the sensor. So it only displays a saturation measurement.
So I think a lot of our audience will be very familiar with pulse oximetry. So when you're applying oximetry to the brain, what do they kind of need to know about regional oximetry?
So they need to know that unlike pulse oximetry, which is based on a small pulsatile arterial signal, cerebral oximetry is based on the non-pulsatile arterial blood, pulsatile venous blood, and background tissue absorption. So the signal is much stronger than pulse oximetry, which is why in conditions of low perfusion, cerebral oximetry will still provide measurements. And a fundamental difference is that the cerebral oximetry saturation has both arterial and venous compartments. So in the sort of average vascular bed, 70% of blood is in the venous compartment. So with cerebral oximetry, you have both a supply side, in other words, the arterial oxygen saturation and content, similar to pulse oximetry, but you also have an indicator of cerebral venous oxygen saturation, which sort of reflects cerebral oxygen consumption and cerebral oxygen extraction. So changes in those will be reflected on the venous side and in the overall cerebral oxygen saturation measurement.
So it's clearly much more complex than simply putting a pulse ox sticker on someone's forehead. So thanks for kind of clearing that up for some of the misconceptions. How did you get involved with near-infrared spectroscopy?
So in 2001, I was fortunate enough to be a co-investigator on a randomized trial led by Jane Newberger. She was evaluating hemodilution during infant hypothermic bypass and comparing hemodilution to hematocrit of 25% versus 35%.
So that kind of brings us to the article of the month, the cerebral oxygen saturation in children with congenital heart disease and chronic hypoxemia. So just to start with, what was some of the key questions that you wanted to answer with this study?
So the key question was whether children with cyanotic congenital heart disease have cerebral oxygen saturations within or below the range regarded as normal. So that was one fundamental question. A second issue, because we were measuring jugular bulb samples on blood gas analyzers, was whether cerebral oxygen extraction measured as moles of oxygen per 100 moles of blood differed between cyanotic and acyanotic patients.
Can you explain for our listeners maybe a little bit about the concept of cerebral oxygen extraction?
So cerebral oxygen extraction is the amount of oxygen the brain takes up from the arterial blood. The unit is moles of oxygen per 100 moles of blood. Now, to obtain this measurement, you either need some invasive measure to get jugular bulb or some other cerebral venous oxygen saturation, or you can do this with magnetic resonance imaging, but neither of these are suitable for bedside use. So what clinicians have done at the bedside is used arterial oxygen saturation and cerebral oximetry to provide an estimate of cerebral oxygen extraction. And the two ways that have been done is looking either at the difference between arterial and cerebral oxygen saturation, or at the difference between arterial and cerebral oxygen saturation divided by the arterial oxygen saturation. This is called the fractional oxygen extraction, and that's used to adjust for varying saturations.
So, taking that into account, what do you think were the key findings in your study, and were they surprising to you?
So the key finding was that children with cyanotic congenital heart disease who are adequately compensated for chronic hypoxemia had cerebral oxygenation values within or very close to what's regarded as a normal range. The second finding was that cerebral oxygen extraction, when measured in moles of oxygen per 100 mils of blood, is similar whether your arterial oxygen saturation's above or below 90%. So these findings were surprising in that we've noticed from clinical use and for performance of the validation study on the foresight that the difference between arterial and cerebral oxygen saturation is not constant, but decreases with decreasing saturation. So if you have a healthy patient with an arterial oxygen saturation of 100%, the cerebral oxygen saturation on average would be about 70%. So this delta is 30%. If you have a patient with an arterial oxygen saturation of 80%, you shouldn't assume a 30% delta. So if a patient who's cyanotic with a saturation of 80% has a cerebral oxygen saturation of 50%, this may be a baseline for the patient, but it shouldn't be regarded as a normal baseline.
So, taking this into account, how do you see these findings influencing sort of practice or your personal practice for these patients?
So I think whether you get a cyanotic patient or an acyanotic patient who, when you start taking care of the patient, has a cerebral oxygen saturation outside of the normal range, one, you shouldn't assume that it's just due to a low arterial oxygen saturation, and it should prompt an investigation of the other factors that can influence cerebral oxygen saturation. The other important thing is, because we found that an increase in hemoglobin is an important compensatory mechanism for maintaining cerebral oxygen delivery in cyanotic patients, if you're doing a procedure where there's a large potential or ongoing blood loss, patients who are cyanotic and who live with hematocrits in the 40s or 50s, you may consider transfusing these patients at a higher level of hematocrit than you would someone with a normal oxygen saturation.
Do you see this type of work influencing transfusion practices in this patient population? Will this be sort of a standard monitor, you think, as we take care of these patients in the operating room that really needs to be done?
I think a cerebral oxygen saturation in isolation cannot be used to decide for or against a red blood cell transfusion. The thing with cerebral oximetry, it's a saturation measurement, but there are many underlying factors which influence that measurement. And, on the supply side, it's arterial oxygen content and cerebral blood flow. And on the consumption side, it's cerebral oxygen consumption. And there are multiple factors, as most people who do anesthesia know, affecting the oxygen supply-demand relationship. So I think you need to interpret your cerebral oxygen saturation in the bigger context of what's going on clinically with the patient. So that, I think, is one main point. A second main point is there's a lot of variability in cerebral oxygen saturation measurements between various patients and within patients, and within and between various commercial oximeters. So I think you need to conceptualize which zone the patient sort of resides in when you're taking care of them, and is it changing? Is the cerebral oxygenation going up or down? And you need to interpret that in the clinical context.
Do you routinely use cerebral oxygen saturation measurements for non-congenital heart disease patients?
It's not routine in our institution in the operating room, so it would be selective based on the anesthesiologist. In the cardiac ICU for the non-cardiac surgical population, that will also be selective based on the clinician.
To summarize, I think this work, as you said, does show that one number is not necessarily applicable to everybody, but we should take, all sort of derangements, I guess, in cerebral oxygen saturation, shouldn't just take it for granted, as you said, that this patient sort of has a low oxygen saturation to begin with, so we shouldn't be alarmed about that. I think because obviously I use cerebral oximetry in my practice in adult cardiac patients, and I think one of the concerns some of us have with this particular monitor is sort of what signal we get out of it and kind of how serious a desaturation do we have to aggressively treat it, and what should we do? So I think those are some of the questions. Where do you see kind of this field going? What do you think are the next steps that needs to be taken?
So there are other investigators that have been using cerebral oximetry to evaluate cerebral autoregulation and determine the lower limits of autoregulation. So that's one area of active research. What our group is doing at Boston Children's Hospital is we're using more advanced NIRS instruments, so non-commercial NIRS instruments, to measure elements of cerebral oxygen consumption and to determine whether CMRO2 is a better indicator of brain health than cerebral oxygen saturation.
Well, Dr. Kussman, thank you very much for joining us, and I want to direct our listeners again to the July article of the month in Anesthesia and Analgesia, that's Cerebral Oxygen Saturation in Children with Congenital Heart Disease and Chronic Hypoxemia by Dr. Barry Kussman and colleagues from Boston Children's Hospital. So thank you, sir, very much for joining us.
Thank you for the invitation.